What is the most common electrocardiographic (EKG) abnormality in patients with heat stroke? A. Sinus bradycardia. B. Atrial fibrillation. C. QT interval prolongation. D. Ventricular fibrillation. E. Supraventricular tachycardia (SVT). The answer is C. QT interval prolongation. Answer C. QT interval prolongation is the most common EKG abnormality in patients with heat-related illness. Interestingly, QT interval prolongation is also very common in patients with hypothermia. Other common EKG findings include sinus tachycardia, atrial fibrillation, SVT, right bundle branch block, and occasional ST segment changes. Sinus bradycardia and ventricular fibrillation do not commonly occur. Which of the following is the most specific EKG finding in acute pericarditis? Concave ST elevations. B. Convex ST elevations. C. PR depressions. D. Hyperacute T waves. E. Primary atrioventricular AV block. C. PR depressions. Answer C. The EKG changes over time in patients with pericarditis. Acutely, concave ST elevation and PR depression with tall T waves are seen. Depression of the PR segment is the most specific EKG finding for acute pericarditis. Concave ST elevation is also common, but can be seen in a variety of other conditions, including benign early repolarization and left ventricular hypertrophy. An ST segment to T wave ratio of 0.25 argues in favor of acute pericarditis. Convex ST elevations are more likely to be due to myocardial infarction than pericarditis. Hyperacute T waves are seen more often in hyperkalemia and infarction than in pericarditis. AV blocks are rarely seen in acute pericarditis. Chronic EKG changes associated with pericarditis include return of ST segments to baseline, T-wave flattening, T-wave inversion, and then complete normalization after a few weeks to months. Which of the following is the most important factor in determining the risk of rupture of an abdominal aortic aneurysm? A. Age of the patient. B. Hypertension. C. Size of the aneurysm. D. Location of the aneurysm. E. Male gender. C. Size of the aneurysm. Answer C. Aneurysms greater than 5 cm in size are at greatest risk of rupture, although smaller aneurysms may also rupture. Debate exists as to the optimal time of elective repair of asymptomatic aneurysms, but patients presenting to the ED with symptomatic aneurysms should always be aggressively evaluated. A 55-year-old patient presents with palpitations for 1 week. The EKG done in the primary care doctor's office is shown. The patient is sent to the emergency room for further evaluation. Which of the following is the most appropriate next step in management? A. Diltiazem 20 mg IV. B. Esmolol 50 μg kg minute IV. C. Enoxaparin 1 mg per kg. D. Amiodarone 150 mg IV. E. Adenosine 6 mg IV. C. Enoxaparin 1 mg per kg. Answer C. The EKG demonstrates atrial flutter at a ventricular rate of 50. The risk of atrial thrombus increases with the amount of time the patient is in atrial fibrillation or atrial flutter. Emergent management of atrial fibrillation or flutter involves reduction of rate to below 100 and anticoagulation if the duration of the dysrhythmia is longer than 48 hours, unless echocardiogram indicates no cardiac thrombus. This patient is not tachycardic and requires no rate-controlling agents such as diltiazem or esmolol. Amiodarone is not indicated as this may actually terminate the atrial flutter and put the patient back into sinus rhythm and at risk for thromboembolus. Adenosine is indicated for paroxysmal supraventricular tachycardia. It may be used in unclear cases of narrow complex tachycardia but has no role in obvious atrial flutter. A 67-year-old woman with coronary artery disease, CAD, presents with dyspnea, which is her last anginal equivalent. She is known to have a pre-existing left bundle branch block. Which of the following EKG findings, when present into contiguous leads, indicates the highest risk for acute MI? 4 mm of discordant ST elevation. B. 4 mm of concordant ST elevation. C. 2 mm of ST depression. D. Tall T waves. E. Inverted T waves. B. 4 mm of concordant ST elevation. Answer B. The Saragossa criteria were devised to assess the likelihood of infarction in patients with a left bundle branch block. 3 different electrocardiographic criteria are given specific scores. A total score of 3 or greater indicates that the patient likely has acute MI concordant in the same direction as the QRS complex. ST elevation greater than 1 mm is given 5 points. ST depression greater than 1 mm in V1, V3 is given 3 points, and discordant ST elevation greater than 5 mm in the opposite direction as the QRS complex is given 2 points.